gives me great pleasure to be able to introduce Professor Catherine Nelson-Piercy, who is a Professor of Obstetric Medicine and Consultant Physician at Imperial and Guy's and St Thomas's Hospitals. Catherine specialises in the care of women and medical problems in pregnancy, but also pre-existing conditions such as epilepsy, which I'm sure she's going to tell you a little bit more about. And she was also paramount in creating our court booklet on pregnancy, which you can find on the website, but we can also send you out a hard copy if you wanted that, which I'll put my details in at the end if you want to request one of those. But I'll hand you over to Catherine now, and I hope you enjoy the talk.
Thank you very much, Jo, for that introduction. As Jo explained, I am an obstetric physician, which is a very unusual specialty. So I look after women who are pregnant with medical problems. That's all I do. So I'm not an obstetrician, so I don't deliver their babies. And I'm not a neurologist. It's a very sort of niche specialty, but it means I know quite a lot about pregnancy in general. I've been a consultant over 25 years now, and I've met quite a few women with cavernomas, either before they get pregnant for counselling or when they are pregnant. So hopefully you can all see my slides. Just nod at me, Jo. Yeah, thank you. I'm going to try and cover the following topics. I'm going to talk a little bit about genetics and PGD. Then I'm going to spend quite a bit of time going through the evidence about the risk of bleeding from cavernomas in pregnancy. Then I'm going to talk about CT scans and MRIs in pregnancy. Then a few words on surgery. And then, as Jo said, I'm going to cover seizures for women with epilepsy associated with cavernomas. And then a little bit about mode of delivery once you are pregnant. So firstly, genetics. So I know that the sufferers on this forum will know that familial cavernomas are inherited according to autosomal dominant genetics, which means if you just get pregnant and leave it to luck, 50% of children will have the same gene and will inherit the propensity to cavernomas. In order to have PGD, which stands for pre-implantation genetic diagnosis, you first of all need to know what the genetic defect is that you carry. And for cavernomas, there are different congenital malformation, different genetic mutations that will give you a cavernoma. And you need to know the specific one that you have in order to be a candidate for PGD. Secondly, depending on where you apply to have the PGD done, which is usually associated with an IVF unit, that unit has to apply permission from government to treat someone, unless they've already treated someone with a cavernoma before, because effectively what you're doing is testing embryos for genetic mutations, and that is very closely regulated by Acts of Parliament. So the more PGD happens, the more units have expertise of treating women with cavernomas for PGD. And what PGD is, it's basically IVF. So embryos are created using the mother's eggs and the father's sperm. They're put together and embryos are created. And then each embryo created is tested for whether or not it carries that genetic abnormality that causes cavernoma. And those embryos that do not carry the genetic abnormality, which will be roughly half of them, are frozen, ready for replacement to the mother in what's called a frozen cycle transfer. And for women who don't have children already, who are accepted onto a PGD program, then that whole procedure is free, the PGD, the IVF. It has the same success rates as IVF for other causes, possibly higher because most of these women are actually fertile, so they're likely to have good ovarian reserve. So that means that when the doctor goes in to collect the eggs from the ovaries, they're likely to get lots of eggs and be able to create lots of embryos. So I'm not an IVF expert, I'm not a PGD expert, but that is basically what PG is for anyone interested in having a pregnancy but wishing to avoid a pregnancy that carries a baby who has cavernomas. And of course, the other way that we can diagnose cavernomas is once you're already pregnant. Again, you have to know the gene, but you could have what's called a CVS or an amniocentesis. But that means that you're already pregnant and you need to decide, well, what would I do if I found out I was carrying a baby with the same genetic problem? Would I terminate that pregnancy or not? Is it worth the risk of a miscarriage to have those procedures? Right, the next set of slides deals with the risk of bleeding from cavernomas in pregnancy. And traditionally, this was thought to be increased because cavernomas are likely to grow in pregnancy because pregnancy is associated with higher levels of the female hormones, estrogen and progesterone, and increased levels of something called vascular endothelial growth factor, VEGF. And that can stimulate the cavernoma to grow, but that doesn't necessarily mean that it's more likely to bleed. So I'm going to go through some evidence with you, and the papers and the references are all at the top. And I'm happy to share this slide set as a PDF afterwards, for those of you who want to go through it more slowly. So this paper, which is 8 years old now, found an annual incidence of bleeding from cavernomas of 0.6 to 0.7%. And they found that the risk factors for bleeding, so this is non-pregnancy data, were rebleeding, so those patients who had bled already, those patients who had familial cavernoma, cavernomas of the brainstem carried a higher risk, larger cavernomas, younger age at diagnosis, and those with associated venous anomalies. This then is a specific study looking at the risks of bleeding in pregnancy. So this was 350 pregnancies, more or less, in 186 patients, all from what's called the Toronto Vascular Malformations Group, so a large Canadian study. And in those pregnancies, there were 50 hemorrhages during the women's childbearing age, and 3 of those occurred during pregnancy. None of them occurred during delivery or 6 weeks postpartum. So the hemorrhage rate in pregnancy was 1.15% per person per year. And in non-pregnancy was about 1% per person per year. And that relative risk of pregnancy versus non-pregnancy was not significant. In other words, this paper 8-9 years ago showed that the risk of bleeding in pregnancy was not higher. They mainly found that women were getting their information from neurosurgeons and obstetricians. And the majority of neurosurgeons suggested that the risk was unchanged, but the obstetricians were divided. 4 patients never conceived, 2 others started contraception because of the advice that they had received. Now, this is interesting because it's likely that neurosurgeons know more about cavernomas than obstetricians, with all respect to my obstetric colleagues. And there are other more common conditions like berry aneurysms and AV malformations that are encountered much more commonly than cavernomas in pregnancy. So maybe obstetricians were extrapolating from patients who have berry aneurysms and AV malformations. This then is a slightly more recent paper. Again, it's a single study from Phoenix, Arizona, America. 168 pregnancies in 64 female patients, all with cavernomas. 28 had sporadic, 36 had familial. And symptomatic hemorrhage was defined as new onset or exacerbation of seizure activity or any change in the neurological status. And that occurred in 5 pregnancies, and mostly that presented with seizures. And they found that the risk for hemorrhage that caused symptoms was 3% per pregnancy. And again, like the other study, higher in the pregnancies where the women had familial cavernoma. In this study, there were 9 deliveries by cesarean, 5 of which were for obstetric reasons, 8 was for fear of hemorrhage, and 6 was unknown. But in the other 149 pregnancies, these women had vaginal deliveries without complications, which is very reassuring. And lastly, very many thanks to Pat and Joe for sending me this paper, which was in the newsletter, in the Cavernoma Alliance newsletter. So those of you interested in pregnancy have probably read this paper or the summary from the newsletter. Again, it was a single study from America, and this time it was from the Mayo Clinic. It was 90 women, all of whom were less than childbearing age, less than 46, and they all had cavernomas in their brain or their spinal cord. There was a mean age of 31 and a half. 25% had familial cavernoma, and about half of the women had had previous hemorrhage, and a quarter had brainstem cavernomas. Most of these pregnancies occurred in women before they had had their cavernoma diagnosed. 36 pregnancies occurred in women either whose diagnosis was made during the pregnancy or after the pregnancy. Sorry, that's the wrong way around. Whose pregnancy happened after they'd been diagnosed with cavernoma. So of those women, 4 women had a hemorrhage during the pregnancy or postpartum leading to the diagnosis. So that's 4 out of the 36. So in total, that gave them 402 years of follow-up. And in the non-pregnant group, bearing in mind they're only looking at women of childbearing age, so this is a good control group. So if you look at women who with cavernomas who are of childbearing age, there were 42 bleeds, which gave them a rate of 10% per year. And they compared that with the pregnant women, 32 pregnancies, so they had obviously less years of follow-up, but there were no bleeds in those 32 pregnancies. So they found no significant difference in the bleeding risk between the pregnant women and the non-pregnant women. There were no bleeds during delivery, and they felt vaginal delivery was safe. So to just conclude the discussion about the risk of bleeding, the risk of intracranial hemorrhage, bleeding from cerebral cavernous malformations is probably not increased during pregnancy, delivery, or postpartum. And that is, I hope, very reassuring for those of you who are considering pregnancy and are worried about the bleeding risk. The authors of one of the papers suggest that the risk of symptomatic hemorrhage from a cavernoma during pregnancy is not increased, and that if you have a cavernoma, that is not a contraindication to either pregnancy or a vaginal delivery. So many of you will know, if you have cavernomas, that the neurologists and the neurosurgeons like to image them, and they image them mainly with MRI. And it's important that you understand that MRIs are completely safe in pregnancy, whether that's an MRI of the spine or the brain. The confusion in the counselling arises because the danger, if you like to call it that, is from gadolinium, which is the contrast agent that is used with MRI. And gadolinium is important when the radiologist is interpreting the cavernoma, particularly for preoperative evaluation, because it allows better definition of the veins, the arteries, and the size of the cavernoma. So it's used a lot and is necessary when looking at associated venous anomalies and if you're due for surgery. So in general, MRIs are safe, but just to give you the background of why we don't like using gadolinium in pregnancy, it is because of this study, which is a large study performed by some Canadian workers 5 years ago now. And it showed a very slight increase in the risk of stillbirth or neonatal death in women who had been exposed to gadolinium, but that might relate to the condition necessitating the MRI rather than the MRI with gadolinium per se. It also showed a significant increase in the composite outcome of problems in the child. So rheumatological problems, inflammatory problems, infiltrative skin conditions, with a very just significant increase, but it is significant. Interestingly, it didn't show an increase in connective tissue or skin diseases in the baby with a syndrome that gadolinium exposure causes in adults. So you would think that if you gave gadolinium to the mother and it crossed over the placenta to the baby, that maybe the baby would be at risk of this condition called nephrogenic systemic fibrosis, but they didn't find that. So this is what we call a safety signal for gadolinium. So in pregnancy, we try and avoid gadolinium. We do MRIs all the time in pregnancy, but we try and avoid gadolinium if possible. Sometimes it's not possible to avoid gadolinium. So these are the American College of Obstetricians guidelines about diagnostic imaging during pregnancy and breastfeeding. and they say that the use of gadolinium in contrast with MRI should be limited. It may be used in pregnant women only if it significantly improves diagnostic performance and is expected to improve fetal or maternal outcome. So that would include, for example, the mother who needed neurosurgery in pregnancy, because it's going to help the neurosurgeon do their job. And there's no need to interrupt breastfeeding after gadolinium administration. If you have if you're having surveillance MRIs and your neurologist wants to do an MRI after you've had the baby, and they delay the MRI because you're pregnant, which many of them do, then it's okay to have the MRI when you're breastfeeding, and that gadolinium does not interfere with the baby through the breast milk. So that's important to know as well. What about surgery in pregnancy? Well, the first thing to realize is that putting women to sleep with a general anesthetic is very safe in pregnancy. We do it all the time for women who break their legs or need their appendix out or have, require surgery for non-obstetric reasons during the pregnancy. So we have the specialists of obstetric anesthesia who are anesthetists who are very used to anesthetizing pregnant women. So if you need neurosurgery in pregnancy, then the general anesthetic is safe. If you're diagnosed late in pregnancy or you rebleed late in pregnancy after 32 weeks, then it will often be the case that the obstetrician will recommend delivery before the neurosurgery, because that simplifies the surgery, or more importantly, the positioning of the patient during surgery. And the reasons why you might operate or do neurosurgery for a cavernoma in pregnancy are the same as they are outside pregnancy. So a symptomatic hemorrhage or progression, a rebleed, and a strong family history. So a new diagnosis with a venous anomaly, for example. So I'm now going to pause for a second, have a sip of tea, and move on to women with epilepsy and seizures in pregnancy. So the first thing to realize is that if you have a seizure, so as you know, cavernomas present, well, in three ways: epilepsy and seizures, bleeding, or it's found through family screening. Those are the three ways that people find out they have cavernomas. I suppose if you have an MRI for another reason, like a headache, that might be the way that it's diagnosed, which would be a sort of serendipity. But if you have seizures and you have a single seizure, that is very unlikely to harm your baby. Babies are designed to tolerate short spells of not getting enough oxygen, which is what happens when the mother has a seizure. What the baby doesn't like is recurrent seizures. That's harmful to the mother and the baby, or prolonged seizures. And now I need to talk to you about the risk of congenital malformations with the anti-epileptic drugs. If you've got a cavernoma and you've got epilepsy, you'll probably have focal epilepsy, and you will probably be on anti-epileptic drugs. So this is a very old slide now. So it shows you the UK registries, the North American registries, and the European registries. And it illustrates that for lamotrigine and carbamazepine, the risk of malformations in all the registries is very low and very similar to background. But if you're on sodium valproate, Epilim, then the risk of malformations is significantly higher. And that is what has led to the valproate pregnancy prevention program. So I suspect there isn't anyone on this call who is still on valproate who's a woman of childbearing age. Valproate has a dose-response relationship. The higher the dose, the higher the risk of malformations. And it's up to 10%. Not only does valproate cause malformations, but it also, we now know, crosses the placenta and affects the way the baby's brain develops. So it interferes with the verbal IQ in the baby. And again, that is a dose-response relationship. So if you're on carbamazepine, lamotrigine, you won't be on phenytoin. There's no effect on the baby's IQ. But if you're on valproate, that has a risk of a lower IQ in the baby because of it. Valproate has this bad effect on the pregnancy. So the MHRA, which you will have heard about through COVID, they're the body that say whether drugs can be used or not. They're the regulatory body in this country. And they have come out with this very bold statement that both lamotrigine and levetiracetam, so that's Lamictal and Keppra, if you know the drugs that you're taking by their other names, they are safer to use in pregnancy than other epilepsy medicines. And they're saying that the information supports that they do not increase the risk of physical abnormalities compared with the general population. That is a very bold statement. They would not make that statement if they weren't really sure. And that was made earlier this year. So it's a huge advance to women with epilepsy, most of whom nowadays are taking lamotrigine or levetiracetam, that their risk of malformations in the baby if they get pregnant is not increased. For carbamazepine, it's slightly increased, and for topiramate and valproate particularly, it's greatly increased. But that's the good news. The bad news is that if you're taking lamotrigine, which is a very good drug for focal epilepsy, then you need to know that the level of lamotrigine in your blood will fall dramatically when you get pregnant. It falls early in pregnancy. So this is pre-pregnancy, first trimester, second trimester, third trimester, and postpartum. And it falls early, and it goes on falling right up until 28 weeks. So if you're taking lamotrigine and you're going to get pregnant, you need to increase the dose. So you need to get to an epilepsy specialist early in the pregnancy. Ideally, you need pre-pregnancy counselling with a prospective plan about what to do with your lamotrigine dose in pregnancy. Because if you don't increase your dose and you're dependent on therapeutic levels of lamotrigine to stop you having seizures, then you're running the risk of having a seizure when you get pregnant. And that's very, very important to understand. Many GPs don't know that. Many neurologists, most neurologists know that, but some don't. So that's why we now have very clear guidelines. EMBRACE is the Confidential Inquiry into Maternal Deaths, and the RCOG, which is the College of Obstetricians, they have created a guideline specifically for women with epilepsy in pregnancy. It also has a patient-facing information sheet that goes with it. But what it says is that women with epilepsy taking anti-epileptic drugs who become unexpectedly pregnant need urgent access to an epilepsy specialist, because your instinctive reaction will be to stop your drugs if you've had an unplanned pregnancy, but that's a very dangerous thing to do and not recommended. Secondly, they recommend that pregnant women with epilepsy should have access to regular planned antenatal care with a designated epilepsy team that will usually be a combination of an obstetrician, a neurologist, or an epilepsy nurse specialist, and sometimes a specialist midwife as well. So that's a really important message. Pre-pregnancy, we see lots of women with epilepsy who are referred for pre-pregnancy counselling. And the first thing is we try and get them on one drug because that reduces the risk of malformations. We talk to them about the risk. We reassure them if they're on lamotrigine or levetiracetam. Women on anti-epileptic drugs should take a higher dose of folic acid. That's not the dose of folic acid that you buy from the chemist saying, I'm planning a pregnancy. It's a much higher dose that you need to get on prescription from your GP. And it's 10 times the normal dose. If you're on valproate, then we need to try and reduce the dose if we can and give a slow release formulation. Antenatally, we give the general advice for epilepsy to avoid having a bath unattended, because in a bath, if you have a seizure, you can obviously drown. We teach all relatives the recovery position to make sure that if you do have a seizure, the people that you live with know how to manage that. We monitor the drug levels at baseline. And then if you have a seizure in pregnancy, to help us judge how much to increase the dose by. But we increase the dose if you have seizures, usually, unless you've forgotten a dose or there's some other precipitant. And for women taking lamotrigine, we nearly always increase the dose anyway, even if you don't have a seizure, because we don't want to wait for you to have a seizure before increasing the dose. Women with epilepsy should have their baby in hospital. The risk of seizures is increased around the time of delivery, and it's about 1 to 2% during labour, 1 to 2% within 24 hours afterwards. We never stop the anti-epileptic drugs in labour. but we sometimes give an extra drug called clobazam, which helps reduce the risk short term of having a seizure. And then we have protocols of how to deal with seizures in labour. After delivery, all babies are given intramuscular vitamin K. We never leave women with epilepsy unattended. So, you know, you've had your baby, you're holding your baby, your partner goes out to ring his parents, the midwife goes out to fill out the notes, and you're left alone. That shouldn't happen to women with epilepsy. We encourage breastfeeding. The levels of the drug in breast milk are much less than they are in pregnancy and much less than therapeutic levels. So women are encouraged to breastfeed even if they're taking anti-epileptic drugs. And if we've increased the dose in pregnancy, then we reduce it again slowly after delivery, bearing in mind that you're going to be up at night, you're going to have sleepless nights, and that is, you know, as you know, sleep deprivation increases the risk of epilepsy, of seizures. And you might not have wanted me to talk about contraception, but I'm going to, because I never miss an opportunity. And I get very upset in my pre-pregnancy clinics when I find that women are taking teratogenic drugs and they're not on proper contraception. So there are special issues concerning women with epilepsy and contraception. You need a higher dose of the combined pill if you're taking carbamazepine. You also need a higher dose of the morning after pill if you're in that situation. You can have a standard dose of Depo-Provera, or you should use an other form of contraception. It's really lamotrigine and levetiracetam are the common ones, and they don't induce liver enzymes, so you don't need a higher dose of the pill if you're taking those drugs. But I bet you didn't know this. So some couples come to say, and I say, are you using contraception? And they look very embarrassed and say, well, yes. And I say, well, what? And then they look embarrassed, and then they say condoms. And then I tell them this: an average couple using condoms in a year, 18% of that couple will be pregnant in a year. 18%. It is a rubbish form of contraception. Perfect use of condoms, no accidents, no mishaps, 2% of couples will be pregnant within a year. So my message to you, because I know you're listening to me, is if you don't want to get pregnant, don't use condoms. Okay? What you need is an effective form of contraception, which is the progesterone-only pill, an IUD, so like something like the Mirena intrauterine system, or the implant, the progesterone-only implant. These are what are called long-acting reversible contraception. Note that their perfect use and their typical use is the same, because it doesn't depend on you remembering to take a tablet every day. It doesn't depend on your partner using a condom. You stick it in, it's in there for 3 to 5 years, it works, you're not going to get pregnant. Yes, there are some side effects, but forgive me for lecturing you, but not a lot of people know these figures. So I'm hoping you're going to go away and tell all your friends, even those that haven't got cavernomas, because it's really important. So lastly, mode of delivery. This should be determined by obstetric factors. And it isn't the case that women with cavernomas, and I have 2 women at the moment that I'm looking after with cavernomas who have epilepsy, they don't need cesarean sections. They can have a normal delivery. There's no evidence, as I've shared with you, that having a vaginal delivery will increase your risk of bleeding from the cavernoma compared to a cesarean section. But what's important for epilepsy particularly, but cavernomas in general, the pain needs to be controlled, the blood pressure needs to be controlled, and that means that you are likely to be encouraged to have an epidural, and that means you're going to meet an obstetric anaesthetist, hopefully before you end up on the labour ward in labour. That is particularly the case if you have a spinal cavernoma. If you have a spinal cavernoma, the anaesthetist doesn't want to put a needle anywhere near it. So they're going to want to see your MRI result and talk to you and explain whether or not they think they can get an epidural or a spinal, what's called regional anesthesia, whether you would be a candidate for that in labour or if you needed a cesarean section. So I'm going to stop there, Joe, and let people, I'll stop sharing and let people either put questions in the chat or wave your hand at me or just shout out. I'm really not very scary.
I'll ask a quick one while we're waiting. I wrote it down. With the pre-pregnancy counselling that you mentioned, would you advise that for all females who have Cavernoma, or would it just be if they were under medication for something like epilepsy?
I think for epilepsy, it's essential. I think if you haven't got epilepsy and you feel well informed from your neurologist, then there's no need. I think it should be available if women have extra questions that they particularly want to ask. But if you will, I'm sure the people listening are used to meeting doctors where they know more about their condition than the doctor does. And therefore, you know, if you're well informed and you've made your decision, then you don't need pre-pregnancy counselling. Standard pre-pregnancy counselling from the GP about taking folic acid, stopping smoking, getting an ideal weight, being generally healthy, that your GP can give. But the GP is not going to be able to give specialised pre-pregnancy counselling for women with cavernomas. If I meet women with cavernomas who referred for pre-pregnancy counselling who've had previous bleeds, then I will nearly always liaise with their own neurosurgeon or neurologist about that specific case, because it's very specialised. But it's not obligatory. It's up to the woman what she wants to do.
Okay, great. And would she just go to her GP to have that referral made? Yeah.
Yes.
Brilliant. Okay.
Joe, I have a couple questions from the chat line and that got sent in. One right now, Patty, is, so I had a bleed 2 days postpartum. Do you know the statistics of having a bleed if I were to have another pregnancy?
That's a really good question. So the first thing to say is bleeding predicts bleeding. So rebleeding is a risk. But I don't know the specific statistics. I know that for intracerebral bleeding in general, those women who've had a bleed associated with pregnancy have a roughly 2% risk of having a bleed in their next pregnancy, but that is not specific to cavernomas, Pat. So in that particular case, I think it is a risk, but it should, as I've showed you, it shouldn't be higher in a next pregnancy compared to any other time.
Okay.
It's very difficult given the temporal association between having a baby and bleeding 2 days later. It's very difficult not to blame the pregnancy. But I've shown you the data such as they are. I suspect that if that woman had had a normal delivery, then she might be tempted to ask for a cesarean section next time. But I don't think it was the mode of delivery. It's more like to be the pregnancy itself that is causing the risk.
Okay. And if I can ask a couple of others, Joe. One is, I'm currently 9.5 weeks pregnant with my second baby. I have 2 cavernomas in my brainstem, which were discovered on my first pregnancy, and I also had preeclampsia. My question is, what are the risks to my cavernomas of taking aspirin daily whilst pregnant? Should I opt for the lower dosage of 75 grams over 150 grams?
That is a brilliant question, and it's a question I get asked a lot. So in order to answer that question, I have to talk a little bit about aspirin dosing. So the standard aspirin dose to prevent preeclampsia or to reduce the risk of preeclampsia in this country used to be 75 milligrams. Many obstetricians have changed to 150 milligrams based on a study from King's College Hospital that showed that if you give 150 milligrams of aspirin versus nothing, that significantly reduces the preeclampsia rate more than 75 does. But no one's done a study comparing 150 with 75. So we don't actually know that 150 works better. But a lot of people have sort of jumped on the bandwagon and are offering 150. To answer that lady's question, I would want to know at what gestation she got delivered with her preeclampsia in her last pregnancy. Because if it was at term or near term, I would definitely say 75 is enough. If she had early onset preeclampsia and got delivered very preterm, then I would encourage her to stay on the 150 milligrams because there is no evidence that aspirin will increase the risk of bleeding from a cavernoma. You could argue that although it won't increase the risk of bleeding, if you were to bleed, it might make the bleeding worse, if that makes sense.
Yeah.
But if the spinal cavernomas have never bled, and the preeclampsia was early, I'd err on the side of 150. If the cavernomas had bled or the preeclampsia was late, I would err on the side of 75. Sorry to be vague, but I don't want to make the woman give her specific details to the whole of the world. So I've covered all options, hopefully.
Okay, great. And if I can riff on that one more. We had one member who couldn't be here with us tonight who did ask about spinal cavernoma, and you touched on that in a couple of places tonight. Is there anything else you could say about specific risks of spinal cavernoma and pregnancy?
No, I think it's really the issue of anaesthetists and whether or not to have epidurals. I mean, if you bleed from a there's no evidence that spinal cavernomas are more likely to bleed than brain ones. There is some evidence that brain stem ones are more likely to bleed, but we've discussed that, but not spinal ones. So I think the risk is the same, i.e. not increased. But even if it doesn't bleed, they might be in the way of the anaesthetist needle. That's the issue.
Okay, great. Thank you very much.
I've had a direct question. Does it matter how long ago you had your bleed from cavernoma? So if you had the bleed several years ago, will you get the same care and attention now, or will that be different?
Anyone who rocks up in pregnancy saying they've got a cavernoma and it's bled is going to get treated as a high-risk patient and is going to get referred to a specialist service. So I mean, it reassures me that the bleed was a long time ago, but it doesn't mean I think, oh, don't worry, you're not a problem. That's still going to be a relatively high-risk situation compared to all other pregnant women. So she should get referred for consultant-led care.
Brilliant. Thank you. I think Margaret's got a question for you.
There's a couple in the chat as well, which I can take quickly. Ashley, Andrew's asking, yes, it does. I am talking about petit mal as well. So with cavernomas, they're often focal, and those seizures can increase if the lamotrigine level drops. So everything I said about seizure pertains to the focal ones as well. Can I use dalteparin in pregnancy? Yes, we use it a lot to prevent blood clots. It's like aspirin, it won't make you bleed, but if you bled, you might bleed more. But if you've been offered dalteparin to prevent blood clots, then you should accept that offer.
Kathy, I was interested when I was looking up your background and stuff, that you founded or co-founded a journal that was called, what was it called? Sorry.
Obstetric medicine, the
medicine of pregnancy. I mean, why was there that need, and what was the niche it filled? And, because you were talking about when you talked about your speciality.
Well, because it's a slightly political answer, Pat, and the situation is different in Canada. Not so much the US, but Australia and New Zealand, where there are far more obstetric physicians. So specialist physicians, so a neurologist, a rheumatologist, a gastroenterologist, they may or may not know about their condition and pregnancy. Obstetric physicians know a lot about pregnancy and lots of different conditions. So the advantage of us are that we know we're like what used to be called general physicians, but we're general physicians to the pregnant mother. So we know about drugs in pregnancy, for example. There are some specialist physicians. So I do an epilepsy clinic with a neurologist whose specialty is epilepsy, and we sit in clinic together, and he knows a lot about epilepsy and pregnancy, but most neurologists don't. Most neurologists aren't epileptologists, and those that are won't know much about cavernomas in specifically. So I'm not really answering your question, but there was a need for a journal because the obstetric journals don't deal very much with obstetric problems like postpartum hemorrhage and preeclampsia, and the general journals don't deal much with pregnancy. So it's an overlap area which needed its own journal. I just wanted to make sure I've heard correctly. I have a brainstem cavernoma that bled 4 years ago. I had an unsuccessful posterior fossa craniotomy due to my blood levels rising. I'm now trying to get pregnant. So would you say, in your opinion, brainstem cavernomas carry a higher risk of rebleed? I'm not sure. The evidence from the papers, 2 of the papers I've read, would suggest that their risk is higher. But I would want to ask a neurosurgeon that specific question. And maybe your own neurosurgeon, as he's or she has actually been in there and had a look. So that's what I would do in that situation. A higher risk doesn't mean to say too high, given that what we're saying is that the background risk is that cavernomas don't bleed more in pregnancy. So if you're asking, is your risk of bleeding in pregnancy higher? The answer is no. Is your risk in general higher? Then the answer, I think, is yes. But I'm basing that purely on evidence, not my expertise. It's a bit unsatisfactory, sorry. Would you recommend a time frame to wait after a bleed? I mean, I think 6 months would be an absolute minimum. Was it you that had a bleed 2 years ago? Sorry, I've forgotten. But 2 years is long enough. A year or 2 is fine. Should you be consultant-led if you have cavernomas and previous preeclampsia? Well, yes and yes, but the 2 together, definitely. So if you've got a cavernoma, you need consultant-led care. And if you've had previous preeclampsia, you should be seen by a consultant at least once and be offered aspirin. How often should you expect to see an obstetrician? Well, for the previous preeclampsia, again, it slightly depends on how bad and how early your preeclampsia was. If it was mild towards term, then you might just see the obstetrician once, get put on aspirin, and then be discharged to midwifery-led care. If you've got a cavernoma, I would expect the obstetrician to liaise, either send them to an obstetric physician or to liaise with the neurologist. And it would depend if you also had epilepsy. We see our women with epilepsy up to monthly during pregnancy. Should you notify your neurologist directly or via GP? So if you're just pregnant, then you can self-refer for pregnancy care online, which bypasses your GP. But that's not a very good idea, because your GP will have all the letters from the neurologist. So in that situation, I would go via your GP. But if you're in a hurry to get into pregnancy care and you want a booking appointment and a dating scan, then you can refer directly, or you can do both. You can self-refer online, which will get you a midwifery booking appointment, and you can separately tell your GP to make sure the GP, I don't want to lecture you about NHSIT, but you know how dreadful it is, that the GP letters might not get to the obstetrician unless you do something to make sure that happens. Are there benefits of taking progesterone-only pill over a combined pill? If you're on lamotrigine or levetiracetam, well, if you're on levetiracetam, no, they're equally good. If you're on lamotrigine, then the progesterone pill probably is better, because the estrogen doesn't interfere with the lamotrigine levels, which the combined pill can. Is there any links between cavernomas and miscarriage? Not that I'm aware.
Catherine, I had a direct message from one of the members. I'm just asking, is there any additional risks to having a cesarean if you have cavernomas or if you've previously had bleeds?
So cesareans increase the risk in general of infection, bleeding, blood clotting, not establishing breastfeeding, and much more importantly, in your next pregnancy, they do increase the risk of lots of complications. So a lot of women think that cesarean sections are safer and better. They're not. They're actually more dangerous. The NHS does offer cesarean section on maternal request, but not after a lot of people like me have tried to explain to women that they're not safer. It's safer for the baby to be born vaginally because the squeezing of the contractions helps get the baby breathing well. And a cesarean section is a major operation that has the associated risks of bleeding, clotting, and infection.
I have and excuse my pronunciation, pseudo meningocele at the back of my neck following removal of a cavernoma from my brain stem. I've been often offered surgical intervention if I wanted to either repair the defect or place a shunt, but I was wondering if there were any risk factors from this or either potential repairs with getting pregnant in the future.
No, your desire to become pregnant shouldn't be influenced by whether you have further neurosurgery or a shunt. We look after lots of women who have shunts from their brain to their lungs or their tummy, and they don't get in the way and they're not a problem. So you should make the decision about whether to have surgery for the pseudo-meningomyelocele separate from your decision about pregnancy. One won't influence the other.
But also, is there any risk from the pseudo-meningocele itself?
No.
So, okay.
I mean, the anaesthetists, again, are going to freak out a little bit and they might not want to give you an epidural. But other than that, I don't think there are any specific risks, no.
Okay.
There's one more in the chat line, I think.
Oh yeah, if you have multiple cavernomas, are you more at risk of a bleed when pregnant or during birth? I don't think so, because many of those women in those studies had familial cavernomas, had multiple cavernomas, and their risk was no higher. So I don't think it increases the risk. It's more to do with size, is my understanding. If you have a big one, it's probably higher risk than two little ones. It's not the number that matters.
I think you've covered quite a lot there, Catherine. That was really informative. You've certainly refreshed my knowledge on it. Thank you. Yeah, just thank you. Yeah, brilliant. And this has obviously been recorded, and the presentation itself, Catherine's happy for us to put it on our website, so it's there if you want to refer back to it. And we've got some new information and resources coming out on pregnancy and cavernoma soon, which Pat's been amazing in helping us get sorted. So thank you, Catherine, for giving up your evening to come and talk to us. It's been brilliant, very, very informative. Really enjoyed it.
Pleasure. Thank you very much for organising it, Jo and Pat, and nice to see you all.
Yeah, lovely to see you. Hopefully we'll see you again soon. But thank you everyone for coming.
Bye.
Any questions, just email us.